Right. And so we're really talking about the ExTINGUISH trial, which is the first trial of its kind, a randomized placebo-controlled trial of Inebilizumab, a anti-CD19 monoclonal antibody for patients with anti-NMDA receptor encephalitis. And so we've known about anti-NMDA receptor encephalitis for the last 15 years now and continuing to see more and more cases. But up until the launch of this trial, we haven't had any clinical trials that have really been focused narrowly and specifically into patients with this disease. Anti-NMDA receptor encephalitis is a devastating neurological illness. It's an inflammatory autoantibody-driven disease where the body produces antibodies, immune agents that are targeting NMDA receptors that sit on the surface of neurons, generally in the brain, and it causes some pretty rapid changes in behavior and thinking and motor function for our patients. And so a typical patient is going to be on the younger side, more women affected than men, often presenting with psychiatric symptoms that can quickly degenerate into more complex neurologic dysfunction, encephalopathy, seizures, movement disorders, muscle spasms, winding them up in the hospital, especially if there's additional autonomic instability. And many patients require ICU admission for additional support. And perhaps the great thing, maybe the best thing about this disease is that because the disease is caused by antibodies, treating those antibodies can lead to an improvement in our patients and what we think to be pretty good outcomes over time in patients who get that diagnosis early and get the treatment they need. So the treatment up until now has essentially been governed by clinical consensus. Standard of care sort of remains, what neurologists do commonly when we think that there's an autoimmune or inflammatory contributor to disease. And so most patients receive what we can call first-line therapy. That would be usually steroids or IV immunoglobulins, or sometimes steroids and IVIG. Sometimes we'll include plasmapheresis in that sort of first line approach. The goal there being to reduce antibody production, to limit the antibodies that are circulating. Some patients with this disease, particularly young women in childbearing age, are going to have a teratoma, a tumor associated with this disease. If it's present, it's most likely to be present in the ovaries. And if we delve into that tumor, we see that that teratoma has got all kinds of cell types, but a key in patients with NMDA receptor encephalitis, that teratoma has brain tissue in it. So we think that's important in driving the response that leads to the breakdown of self-tolerance, to the spread and development of these autoantibodies that eventually end up in the brain causing their symptoms. And so screening for teratomas and other disease-associated tumors is important. Removing those as early as is safe and practical is also important to treatment. With first-line therapies, we see some patients respond. We see some patients actually improve and go back to normal, which is great. But there's a big chunk of people who don't get there and need additional therapies as well. And so over the last decade, with increasing case series, high quality case series, but still case series informed by investigator intent and consensus, we'll say, we've seen effective use of medications like rituximab. Rituximab, originally developed for treatment of lymphoma, targets lymphocytes, the CD20 marker on those lymphocytes. It's a monoclonal antibody and can be effective in treating patients with NMDA receptor encephalitis. Other drugs that have been used in combination or independent from rituximab include cyclophosphamide, which targets the immune system factors just a little bit more broadly. And so with the combination of tumor screening, tumor removal, first-line therapy and second-line therapy, we see that the vast majority of patients with this diagnosis improve to the point of discharge from hospital, with many returning to their prior living situation, a smaller subset continuing to have some pretty serious disability, and somewhere less than 10% dying as a consequence of the illness or complications thereof.